evening, everyone. Good afternoon, good day. As you all know, my name is Vanessa Vassall, and I am the National Programs Director for Maternal Health and Environmental Justice for Black Millennials for Flint. And I am so happy that everyone is here tuned in either on Zoom or on YouTube for this great conversation. For some of y'all may have noticed on the flyer, this is kind of like a two-part session where we're going to have a conversation with our two expert wise women this morning in the first half of the conversation. And then in the last half of the conversation, I'm going to workshop a couple of resources that I find useful. And of course, any resources that y'all find useful when it comes to finding data for your activism or for your advocacy work when it comes to birth work. So I'm really, really excited. If you are currently tuned in and you have a website that you want to plug that has to do with birth work or community advocacy, please share that with everyone. As you know, this is Black Maternal Health Week 2021, which started on Sunday and ends on Saturday. And that's another reason why Black Millennials for Flint is engaged in this conversation today. So I am going to allow our panelists to introduce themselves first. And since I know Chanel dropped off camera, you already know I'm gonna have Jessica go first. Jessica, go ahead. Tell everybody about yourself, what you do, and anything you have coming up.
Sure. Well, good afternoon, everyone. I think everyone's at afternoon time. Thank you for having me, Vanessa. I'm excited to be a part of the conversation. As Vanessa stated, my name is Jessica Ehule. I am the Director of Programs at CityMatCH. I'm joining you from the Omaha land in Omaha, Nebraska. CityMatCH is housed at the University of Nebraska Medical Center, so that's where we are. Even though we are a national organization, to tell you a little bit about us, we're a national membership organization for local and city and county health departments. And we do a number of different things with them, but we really work with them to really focus on health equity in their areas around maternal and child health outcomes, and really making sure that we are helping to support communities in which moms, babies, and families can thrive. So that's where I'm coming from here in Omaha at CityMatCH.
Fantastic. And over to you, Chanel.
Greetings, everyone. I'm Chanel Porchia-Albert, and I'm the founder of Ancient Song Doula Services. I'm currently on Lenape land in New Jersey, and Ancient Song is located in Brooklyn, New York, and we serve all of New York City as well as Northern New Jersey. And I'm happy to be here with you all today.
Thank you so much. And I already told y'all who I am. And I will say I do have a very personal connection with these two wise queens. Not only was I trained with Ancient Song Doula Services, but I went to grad school with Jessica at Meharry Medical College, HBCU in Nashville, Tennessee. So I'm always excited to see great things. Can you believe we graduated almost 10 years ago?
Ma'am, I just thought about that and I was like, wow.
Yes, tears in my heart. And for those of you who are on the line, if you are representing an organization that does birth work, or you are representing an organization that does community advocacy, please drop your link, drop your social media contact information so that we can all be a community and connect today. So the first question that I would like to ask our panel to really share and express is the following. Many Black and Brown and Indigenous doulas, birth workers, and birthing advocates are often tasked with finding proof that their scope of work is essential to saving the lives of birthing people and their babies. This can oftentimes be a challenge due to the private nature of individual medical patient records for the protection of the patient and the protection of the medical system, and also public-facing maternal death data collection and reporting methods vary from state to state. In your work, what have been effective data gathering strategies that you can recommend to birth workers, to activists, to the wider community of birth advocates? And also, why do you feel like data gathering is important when it comes to developing policy and programs from the grassroots?
Okay.
I know, it's always a lot. I always start with the long one, and then we let the conversation blossom. Y'all know how this go.
Yeah, no, it's fine. I guess I could go first. So as an organization, some of the tools that we've used, one that we find to be very powerful is storytelling. And so really learning from the individuals that we are working with every single day, right? We know that you can't capture everything in a number, right? A number only gives one particular angle of a story, but the actual narrative behind that number is what really drives home the impact of what it means to really center the people that you are working with. Um, I think also, being in community, and really having community as active stakeholders and participants within that data collection, right? So what does it mean to consistently center community voices? And so, I learned from and get the best data from the doulas that we train, from the community in which we serve. And so, how many diapers are we actually having to give out every single month? What does it look like to provide? How much formula are we passing out? Like, how many bags of groceries have we distributed? All of that is data collection. You know what I mean? So it doesn't necessarily have to be someone coming in and feeling like their privacy is being violated, right? Because we also know the ways in which Black, Brown, and Indigenous people's privacy has been used to manipulate them and put them in situations that they don't necessarily feel safe in, right? And so, HIPAA aside, you may have someone who's like, really wants resources, but doesn't want to seek them out because they don't want to give a whole lot of information about themselves. Maybe they're in a DV situation. Maybe they are, were previously incarcerated and feel like if I share this information, like that's going to be used against me in being able to access goods and resources. And so, we really try to make it so that it's easier for folks to be able to participate and not have to do all of those things, right? Maybe it's just sharing your zip code. You know what I mean? Maybe it's sharing your gender identity, right? Maybe it's it comes through, our doulas, are trained to collect data. You know what I mean? Like after they take training, and if the ones who work with us, they're working with an EHR system where they have to like track outcomes and things of that nature. But it's not just the outcomes that we are interested in. Is like, what was the human interaction that you had with the person that you're working with? You know what I mean? Like because you can have, numbers can reflect, oh, wow, like we had a healthy parent, we had a healthy child. But then the actual pregnant person and parent is like, well, actually, like the situation was egregious. You know what I mean? Like I had to go through X, Y, and Z, and I had, an episiotomy that I wasn't looking forward to, didn't want, or I had a cesarean that I didn't need, and so again, it's not just about the numbers, because again, the numbers don't reflect the community voice. It doesn't reflect the patient's experience. Which I find to be more impactful and tells me more about the direction that we need to go in as an organization, and how to truly center community. It also carries a lot of weight when you're thinking about policy, legislative policy, and reform. You know what I mean? Like all of those things are, when you're thinking about any kind of bill creation, community is the first people you need to talk to. You know what I mean? It's not like, oh yeah, I got this idea, let me just bring this forward. It's like, okay, but does this resonate with the people that it's going to impact most? What are the unintentional consequences that can come from that? And have the people had an opportunity to weigh in on it, to really give voice to it? And are they participating in the process, like going and speaking to the legislators themselves and being able to participate? And all of that is like essential, I think, to any good bill. And really holding people accountable, right? Because then folks can't say, well, I didn't know. It's like, no, you didn't know, because guess what? We spoke to the people first, right? So, and I think that that's where true equity and accountability and transparency starts to come in, when we, and where we really truly start to center. I don't like to use that word marginalized, but like where we are really centering community, you know what I mean? And those who are most impacted by the intersections of racism and, housing insecurity and food apartheid and all of the things, environmental injustices that present themselves every day.
I would second everything Chanel said, because that's exactly like down the road that I was thinking. Data is important, right? But I think when people hear the word data, they automatically think numbers, but data is your story. And I think if people understood that both the qualitative and quantitative come together to tell a full story. But I think the thing that I thought about with this question, Vanessa, was first, like, why? And you have to understand why. If you're going into a community to just be extractive, to take data and be like, okay, I'm a helicopter in and then helicopter out and be like, okay, bye. That's not the right approach. If you really need information to support your work or to support a funding opportunity, one, like Chanel said, involve them from jump. From the beginning, from ideology, like forming phase, not once you already have the funding and now you're like, oh, we would like to invite you to the table. No, build the table with them. Make sure they are right there, right alongside you. So I think that the important piece is to remember that you're telling a story with this data, and the story is the community story. It is not like let's say we work with health departments, right? We try to also make sure that the health department understands you are an integral part of community. It's not those people over there, right? If you're going to be in true, authentic relationship with the community members and really move towards the elimination of the disparities we see, if you're really going to talk about addressing issues of racism and bias and oppression and the health inequities that we then see, you have to be really honest about where you're coming from, especially for us that work with health departments. Health departments are part of the institution, right? You have white supremacy threaded into institutions. You have to be real about that and be honest about that with yourselves within organizations and work to undo that. But just think about why are you collecting this data? Like, don't just collect it to collect it, because you need to respect people's information, whatever that might be, however that might be, whether it be in a qualitative or quantitative piece. You have to think about how it's being collected, because what type of mechanism are you using? Making sure that you have people that you want, for one, the organization, build trust. You can't just go in and start taking stories and data. You have to actually build an authentic relationship with the people that you're working with. It cannot be extractive. That is not the right way. We've also seen that doesn't work. We know that. So we need to stop doing that. It does not work. It is not effective to go into communities and say, hey, just fill out this survey. No, we have to do everything in partnership. And when you're sharing that data, you have to also have a plan for how is it being collected, how is it being shared, making sure it's shared in a respectful way, and how is it being used to return back to the community. It has to be full circle. You can't just go and take and do on the side. Everything has to be well informed. So.
And can I ask on that, because I'm really glad you mentioned like health departments. Health departments tend to be, when we think of public health, or when we think of data that's supposed to be accessible to the community, we almost feel like that's like the first place that people send folks. They send them to the health department, send them to the CDC, one or the other. When it comes to the health departments being accessible, or us interacting with them in a way that's not, like you're saying, not oppressive, and because those big institutions, they just perpetuate white supremacy in every move, but it puts you in a tough position when you're like, well, I want to help my community. I want to utilize the health department. I want to utilize these resources. Can you guys share any experience of a time where you felt like it was an ideal experience, where it was an equitable partnership?
Yep.
What does equitable partnerships look like when it comes to government institutions or funders or these other nonprofits, especially the very, very white nonprofits? What does an ideal partnership look like with us in experiences that you've had?
Sure. We've actually had some health departments that are really great at working with community-based organizations, birth workers, doulas. That looks very, very different from like your everyday status quo, right? That means their first order of business is not going in with their order of business. It means really just coming in and having a conversation, building that relationship first. That relationship and trust building may take you a little time, and that's okay, because you all have to show up and show that you are there for the real reasons, right? We have a history of our institutions being extracted from our communities. So now, if you really want to come in and do the work in true, authentic partnership, you have to, number one, come in and just say, We want to get to know you. And we are right here and we're not going anywhere. And so I think that has been step one. We've seen for those larger institutions that have worked, like real tangible things that they've been able to put in place to work with that is like if they were having meetings or gatherings of some sort, even if it wasn't like a formal, like we're trying to figure something out, any type of gathering, provided transportation, provided childcare, provided a meal, provided a stipend every single time. That they met and got together. Those communities that we've seen that have been able to do that, and sometimes maybe that budget hasn't been available within a health department, right? But they leverage partnerships of local foundations or other partners to be able to cover that piece. So we've seen people that have been able to really start from step one of I want to get to know you, and then make sure they have all of those supporting pieces in place before starting the conversation of, okay, and we need to do this and we need to do that. They don't do that at all. You go in and you formulate whatever that strategy is with the community, with the birth workers, with those that have been working there already, right? So that's what we've seen. You have to go in, you have to be real and honest, and you have to show more than you say.
Yeah, I would say in my experience, I was a consultant for the New York City Department of Health, in which they had the SRJ CEG, which was a community engagement group, really working from a participatory perspective, and getting community involved. And I think that the initial steps of it were very successful in really centering and being intentional about centering the conversation around community engagement. What does that really look like? To have community-based organizations at the table, understanding people at the health department are getting paid to come into those spaces, and sometimes community-based organizations don't have the funding to be able to pay someone or an activist for that matter to come and sit at the table and to provide information and to engage with people. So like, what does it mean to provide a stipend for someone? When they come to those meetings, the transportation, the food, the childcare, as you mentioned, especially as you start to, work with those who are directly impacted and really wanting to get them involved in the situation, like making sure that they have the necessary social supports to be able to do that in an equitable way. I think it has potential to grow and to flourish, but it really takes for a supportive administrative body for that to continue, because you can have people who are on the ground who you're working with from the health department who are genuine and really wanting to center those conversations and really do intentional work. But then they are put it through the limitations of their bureaucracy of the institution, and or when there's a transfer of power in terms of that administration, if that new incoming administration doesn't have the same principles guided, you can easily see a program be no more, right? So I think it's really important that with any kind of equitable partnership, we're talking about the longevity of it and the sustainability of it. What does it mean for, a new commissioner or someone to come into place and now take over? Do they have the same principles, of really wanting to center racial equity and accountability within community? Are they really looking to be not just an institution in the community, but an extension of that in a holistic way? But also understanding that within that relationship, it's something that is going to be ever evolving. It's also something that's going to bring up difficult conversations because of the history that, community has had with public institutions, and really trying to understand what that means and, taking and being really humble, right? What does it mean to like just be really humble about the approach and understand that it needs to change over time? You know what I mean? That it's what you may have come into doing to address a particular situation, may start to evolve into something else where now you're talking about something else and you're trying to center those things. What does that look like? And if it's, not being done from a perspective of truly listening. And I should say, not just listening to, again, community, but also your staff. You know what I mean? Because I find that, again, there's a lot of people with good intentions who really, really genuinely want to do the work, but then who are put in this chokehold of, well, you can't do that, or we don't do this, or we don't have the funding for that, or not wanting to give the money for this. And it's like, so why did you say you wanted to do this in the first place? You know what I mean? So yeah, if it doesn't have those, necessary components of like, again, transparency, accountability, sustainability in terms of administration, change, centering community and conversation, understanding that there's a level of fluidity, meeting people where they are, not where they expect them to be, and then uplifting, what does it mean to be humble in the approach? You know what I mean? That there are going to be uncomfortable conversations that will be had, but they are necessary for the growth of not just the community, but the individuals who work in those communities, because they're an extension of those, you know what I mean? Every single day.
I appreciate this. So I'm scared, I have, and I'm going to try to like phrase it in a little bit of the way that's on the paper. I provided them with some questions, y'all. But I really want to talk about, right now we have white people's attention, right? Like right now, y'all got to work with us right now. You killing our men in the street. You killed Breonna Taylor in her sleep. Like y'all not giving us no justice. And now you're like, oh, well, doulas are this, and we want to make them accessible, and let's come up with legislation to do this and this. But a lot of, and you kind of, both of you have already alluded to this, a lot of the labor and a lot of the time and a lot of the investment that they want doulas and birth workers and midwives to do, that's really not equitably compensated. And it can be very re-traumatizing and re-triggering to say, oh, let's have a focus group and talk about that time a baby died. Like, let's talk about this terrible experience that you observed, and then let's write about it. I kind of want to talk about this situation where I feel like sometimes birth workers, activists, community health workers, I feel like their time is like taken advantage of, and their scope of work is viewed as something that can push an agenda forward, but it's not really looked at in the grander scheme of this person is a professional, but they're also a human, and they also need care considered to them when it comes to preserving their spiritual wellness when they're already doing a job that is very, very spiritually, you exert a lot of spiritual energy when you're taking care of a woman who's getting ready to have her child, when you're taking care of a birthing person and their family that's getting ready to have a child. And then you want this partnership that supports the bigger initiative, but isn't necessarily taking in consideration that you need consideration. You might need resources. Do you guys see what I'm saying? Mm-hmm. A lot of times this particular conversation about data and evidence, like Chanel talked about, well, both of you talked about when it comes to stories and things of that nature, the person that's actually the one doing the legwork is not the one getting the credit for it. The person doing the legwork is sacrificing a lot more. And I always have a lot of concerns about that. I have a lot of concerns about the birth worker workforce being taken advantage of because they're needed to push an initiative forward, but then they're not protected and preserved when that initiative, like you said, when that initiative ends. So I don't really know if this is a question or if this is just me talking off the top of my heart, but what do you feel as if, how do you feel we can protect doulas? How do you feel that we can protect the birth worker workforce when they're so essential, but yet they're almost used as like a mechanism or as like an instrument or a tool to just get something moved forward? Does that make sense?
Mm-hmm. Yep. Yeah. So, go ahead, Jessica.
No, go ahead. No.
So I was going to say, one, like the doula should never be seen as an individual who is to remove the burden of years and years of oppression, structural and institutional oppression, because it's not the job and the role of the doula to be able to do that. And no one doula and no doula organization can do that. I find it interesting within the context of a conversation that, now the big thing is like doula this, doula that, doula this, doula that, which I appreciate. But also on the flip side of it, it's also, but what does it mean? If you're saying that I'm essential, if you're saying that my organization is essential, if you're saying that the people that serve this organization are essential, then why is it that the same institutions that have the same poor outcomes still continue to get funded, but the ones that are doing the actual work within their communities that are working tirelessly, how many hours, days to be able to support a family, are still making pennies to the dollar or working hand to mouth, or the organization has to struggle to continuously, find grant funding, and there's a perpetual cycle of not listening, right, to truly hear and to make change, but to listen because they want to say, oh, well, we spoke to you and we got your input. And so, within the context of the doulas, people are like, oh yeah, doulas are great. Yes, doulas are great, but it's an and too. And you need to support them in equitable ways, so that, because these are individuals who have families, who are trying to work within a system that doesn't see them as full human beings. So you have you're supporting Black, Brown, and Indigenous families as a Black, Brown, and Indigenous person yourself, who oftentimes isn't seen as being met with the same level of disdain and condescension when you walk into the space. And so, what kind of internalized trauma is happening to the individual who's there? What happens to mental health supports that need to be in place? What happens to really talking about equity in the form of sustainability, so that someone doesn't feel like they are in a space where they have to pick and choose how they choose to show up for people, because of the fact that they have to learn, they have to live, you know what I mean? And that's not a way to live. And so a lot of it becomes intellectual masturbation, where people just running their mouths and they're not really doing anything. So like for me, it's like, all right, so are we ready to show and prove? Like, what does it mean for these people to say, well, if you're saying that I'm essential and you're saying that I'm necessary in a space, well, then that means that as someone who is essential and necessary, then you need to put the necessary supports in place so that I can do my job effectively and to the best of my ability, right? As, whether it be the doula, whether it's who is looking for sustainability in terms of finance and positionality within their role, you know what I mean? Whether it's the midwife, getting equitable reimbursement through Medicaid, or even someone who's aspiring to be a midwife, what does it mean to have, your education be paid for? And so a lot of this goes under the fact that it's, as you mentioned before, having different states and policy, different states have different ways in which they guide things. Because we don't have a necessarily umbrella structure within the context of the United States, like most developed countries do, you find these like puzzle piece ways of like trying to fix things, right? Or a Band-Aid, or let me put some like, Bassetrin on that real quick, boom, 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 cut that up, you know what I'm saying? Put a butterfly stitch and we good. And it's like, no, how about we actually like heal it? And that's the problem. Like what people are trying to do is they're trying to heal something from on the surface level and not trying to do it internally, which really needs to happen in order for us to like have, equity, for doulas to feel like they're being respected. You know what I mean? For families to truly get what they want. Because otherwise, then yes, it is a game that they're playing, where they're playing to your emotions and what it is that you need at that particular moment. And it also plays to the same narrative of where you're not centering hope or joy in the lives of Black, Brown, and Indigenous people. All you're doing is perpetuating harm, because you keep giving the same narrative of, well, Black people are dying, Black people are dying. Okay, so are you trying to fear me into not having any more children? Because I already got the obstacles of racism and all those other things coming at me at one place. So now I got all this other stuff that's coming at me. And now here you come talking about, well, I'm going to die. So what? Maybe I just don't have children. So if that's the case, then is that what you're really trying to accomplish? Because if you're trying to accomplish that, you're starting to do a good job. Like, it's ways to be able to send a message to someone where they get the information that they need, but they also are centered in, oh, wow, but I still feel hopeful in this. Oh, I know I have this like supports that's necessary in place to be able to do this. Oh, I can say like, it's Black Maternal Health Week. Like, these are the different places where I can go and I can get information and education, and I can feel centered and whole, and I can center Black joy and all of the things that I need for myself. If we're not having those conversations at the same time, then everything else is foolery, if you ask me. You know what I mean? It's just people talking for the sake of talking.
Right. Absolutely agree. And actually, Chanel, where my mind went is one of the things you said, specifically when we're thinking about doulas, midwives, birth workers of any sort. Since we work in health departments, I'm just going to talk also and group the BIPOC community that works within health departments, that often sits in the role of like talking about these things in spaces, right? So people who are actually impacted by these disparities in health outcomes, who are doing like the legwork, right, of bringing this out. all those folks. I think that we need to take the burden off of the BIPOC community. And to do that truly, especially within our institutions, is probably, if you are doing it right within an institution, you should be very uncomfortable. And it's okay. It's okay. Like anything that we do where there's discomfort, we grow from. But the thing that I thought about around this question was there is individual and organizational work that needs to be done to take the burden off of our birth workers, especially our birth workers of color, right? And so we're talking policy level things, but policy, like big policy and little policy P levels, right? So doing the work around like Medicaid expansion and thinking about that, and how can you, wherever you are, state, local, federal level, support that so that we can have that in place so that people's schooling is paid for, so that there's reimbursement and things of that nature. But also, and what are you doing within your institutions that might be intentionally or unintentionally oppressive to the people? And how are you really like analyzing that and digging in? I mean, if you really start to dig into what's happening, you start to notice like, oh, we could do this better or that, or why do we do this at all? It's because of those policies that have just been brought along, and it's just what you do, but it's all centered in whiteness and white supremacy. And so when we're thinking about supporting birth workers, when we're thinking about supporting our staff, when we're thinking about supporting Black, Brown, and Indigenous birthing people, we really have to take a look at ourselves first. And I think that kind of upstream look, if you will, like thinking top down, I think every way, right? Upstream, downstream, midstream, we need to be doing work in all the places. But I think that the hardest work, yet the most impactful work, will be at the work that we do inside of institutions before we go outside and start to try to say, hey, can we partner and work with you? Because now we understand how we've been entrenched in the system and how we can work to undo this. And it is an ongoing thing. You don't come to a point and arrive and check mark. It is something that you always have to do and always have to be aware of. It's just it's in the water that we're swimming in, right? So that's what I thought of in that question. I was like, there's work that we have to do at the individual and organizational level, both in. So.
I appreciate all y'all wisdom. See, this is why I asked y'all to come talk to us today. So I told y'all we would just do right about at a half hour, but I really want you both to share with the folks anything that you have coming up or anything that you're currently working on that is impactful and important in your community or nationwide, because I really want folks to engage with you, or to learn how, based on the work you're doing, they can continue to engage in their communities.
I guess I'll start off. So as I stated at the beginning, CityMatCH works primarily with local health departments, city and county, but we have a new project just started that's around state and local alignment. So if you look at like maternal and child health outcomes at the state level, previously, they weren't really aligned with what was happening locally. And so we're trying to help them to say, you can't have like these ideas here if you're not speaking to one another and if you're not working with the community. So we have a project in which we're trying to align all the pieces, because we've lived in this space for decades where folks, like that piecemeal thing you were talking about, Chanel, folks are just doing stuff over here, over there, here, let's band-aid it, sew it up, good. No, let's try to align all of our efforts, because there's different things we have to do at each level, right? To support the work and to support the health and well-being of our communities. But that's one of our projects that we have going on that literally just started. So they're starting to, like, maybe 2 weeks ago. So that just started recently. The other thing that I would uplift, anyone doing any work around maternal and child health, CityMatCH, we have our conference in December. Our portal for abstracts is currently open right now. I think it ends April 30th at 11:59 p.m. Pacific time. So go ahead and get your abstracts in if you would like to be considered. And it'll be in New Orleans. We pray, okay? It'll be
I pray too, because
so,
I'm overdue for a trip to New Orleans.
We pray. So we're trying to do a hybrid, so it'll be some virtual options as well, just because we know some people won't have the permissions to travel depending on their organization. But if you can, you get accepted, we are we have a spot for you, hopefully. So please do submit. We love to hear about what's happening all over. I'm sorry, I'm in a room that has environmental safety precautions in here, which is good. But we would love to hear about the range of things happening across the country from people. We learn from you all, our members learn from everyone, and it's just a good space to share and network. So I lift those up.
And please drop your contact information in the chat that you would like for the public to have. I appreciate that. All right, Chanel, Ancient Song, what's up with Ancient Song these days?
Ancient Song. So tomorrow I'm doing a fireside chat with Anna Malika Tubbs, who wrote the book 3 Mothers for Black Maternal Health Week. I'm also going to be in conversation later on in the week with Rachel Carley, talking about mental health and the Loveland Foundation and how we can center hope and joy. Ancient Song, of course, has ongoing giveaways each month for community members, where if you need like essentials, you can come and you can get them. We also are prepping for Decolonized Birth Conference that'll be coming up. We're thinking about making it, hybrid and in person as well, but we'll see. In September, I'm looking forward to CityMatCH because I've done CityMatCH before in the past. And CityMatCH is always a good conference, you all. So
we try to have a good time.
It is a good time.
I had a good time in Rhode Island.
Yes.
Yes.
It was a good time. You get to like really engage and network and talk to people and see what people are doing. And so I hope to come to CityMatCH in New Orleans because I'm ready to go somewhere. I'm ready to go to some in-person things and see some human beings and feel some energy. But yeah, I mean, like, please, continue to, go to our website and follow us online on Instagram and IG. And look out for the things that we got coming up.
That is fantastic. Well, I'm so grateful for both of you all for being here. Y'all don't log off. We got a second half to the event. And once again, thank you to our panelists. And if y'all want to stay on, you're more than welcome to. If not, I'm gonna follow up with you. But thank you again. Everyone check out CityMatCH. Everyone check out Ancient Song Doula Services. And by the way, congratulations, Ancient Song, for opening up a location in Jersey. When I saw that, and then I saw the window, and I was like, oh, I know where that is. I can see what was across the street. I was just like, this is fantastic. All the work you've been doing anyway, advocating for the tri-state area and the whole region. It's amazing that you now have another physical space to uplift that work and to support the doulas in Jersey as well. So I'm so grateful for both of you. Thank you so much for your time.
Thank you.
Thank you. Have a great day.
You too. All right, y'all. So we're going to switch gears to the second part of this session where I'm going to share my screen and workshop a few things. Let me tell you all how excited I am to do this workshop with you all. For those of you who do work similar to the work we just discussed or are independent researchers and are oftentimes kind of like, I don't know where to find this data that we talk about. Chanel and Jessica already mentioned, obviously storytelling is such an important part, but sometimes there's like hard numbers that are being asked for and you may not be able to find them. So I'm just going to show you a couple of easy places to find those things that I have felt are particularly useful. And then, so I'm gonna show you a couple resources and I'm gonna actually workshop a particular tool that I like. So I'm praying that I need y'all to get into the chat and tell me that you can see my screen. And let me see if I can see y'all at the same time. Somebody tell me whether or not you can see my screen so that I know. Okay, here we go. I knew this was, let's see. Hold on, y'all. It should, oh, I guess I can't see Zoom while I'm sharing my screen. So hopefully y'all can see it. And if not, I'll just cut it says you are screen sharing. So I'm going to assume that I'm screen sharing. So I'm gonna do this real quick so I can make sure that I can see the chat at the same time. So the first tool, this is actually not the first tool I'm going to show you all. I'm just going to show you all a couple of places where you can just like find really quick statistics. I really hope y'all can see my screen. So the first resource is Parastats by Marchadimes. Marchadimes, as you guys know, is generally focused on babies, but they have been doing a lot more getting data for moms as well, so maternal and infant data. As you can see, when you come to their website, they just have some some things scrolling across the screen. But if you want to really specify your community, like let's say if you're in, I'll just do Georgia, and you specifically want to get information for your state or even your city, this will show you a county map of Georgia, right? Preterm birth. But if you want to even go even further down, actually, that's not. If you want to get a different topic, then you can go here and look at a variety of different topics, including information about maternal health and not just infant health. And something that I like, let me see if I can get the data from Georgia. I do this a lot with the state of Maryland, but sometimes you can click something and it's not information that can be put on a map, but it's just like a list of statistics. And so I find that to be particularly helpful. I would encourage you, if you're okay, it's not gonna work, that's fine. There may be information like this where there's statistics. In 2009, this number of women in Georgia had WIC or something like that. So you're gonna not only get images and maps and things like that, but you're also gonna have the option to have some narrative. But make sure that when you're getting this information that you either save the link or something, or get the source at the bottom of the page, because even if you're screenshotting a map or something like that that you want to use in slides or provide to a family or provide for something, you want to make sure you always have the source. So PeerStats is great. In the doula world, there's a lot of work that we do that people consider quote unquote alternative, or they consider it to be something that they think is all new and different, but it's something we've been doing for hundreds of years, or that they're doing in other countries every day. And here, just because someone is not making money off of it, or a corporation has not found a way to put a price tag on it, somehow it's alternative. I have found a fantastic website, and I love the folks over at EvidenceBasedBirth, and they have a variety of different topics that they put on here. I always am sharing the placenta encapsulation page, because I don't know how many times a week the conversation about placenta encapsulation comes up. They have videos, they have, you see where it says links and resources, they have evidence-based research from a variety of different universities, institutions, both domestic and international. But I really love this website because it's very inclusive of topics that aren't just centered around clinical medicine and just centered around what they would consider like Western medicine. I remember not so long ago, someone asked me a question about evening primrose and about natural ways to induce or things like that. And I was able to find it here. Evidence-based birth gets like 1 million hits a month. I'm not, their what you call it, brand ambassador or anything, but I love this page, and I also encourage it not only for doulas and birth workers and advocates, but for researchers and for students, especially if you're someone like me who kind of straddles that line between being both a birth worker and a scientist. And sometimes the questions are pulled in both sides, but this website does a really great job of bringing those two things together. So obviously in the United States, the CDC, getting CDC data is like, that's our standard, right? So every week, the Morbidity and Mortality Weekly Report, or the MMWR, comes out. And there's a variety of information about there, not just about moms and babies. I just pulled up this example because medical or recreational marijuana is legal in a lot more places now. And so I just wanted to use this as an example of a way to find data on something that also is emerging, but there is research on it. So if you go on here and you click in the search box and you type in whatever it is, let's say you typed in marijuana use during pregnancy and you came up with this paper, and you're like, I'm not trying to read all that, Vanessa. Why are you telling me? Look at all them words on that page. That's doing way too much. This is very academic. Or I got something in 15 minutes. Like, I just want to tell somebody something because I'm trying to get this grant. Something that I like about MMWR is when you look at it on the PDF version, or if you look at it on print, there's a blue box. The blue box, just like macaroni and cheese. And the blue box shows you the quick and clean. The quick and clean. What do we already know? What's new? And what does this mean? So I like, if there's a topic and it's, in this case, 6 pages or maybe it's 38 pages, and I'm like, okay, what do we already know about marijuana? What do we know that's new now about marijuana and pregnancy? And what are the implications in public health or maybe in your work? And once again, I'll say the same thing I said before. If you screenshot, or clip graphs, just make sure you get the citations that go with it as well. So MMWR is always dope. And this was the paper I just showed. Another option is prams. It's also by the CDC, but it's the pregnancy risk and the pregnancy risk assessment monitoring system. The thing about prams is, one, not every state participates in it, but I basically call it like the pregnancy census. So they get information from pregnant moms. But like I said, because not every state participates in it, you may not have it for your state. In particular, if you're in a southeastern state, you either may not have it or you may not have the data that is, you may have data they're not asking them questions, or they're not filling it out, or they're not filling it out with care, right? They're just throwing it together, and then the analysts at the CDC are like, well, what are all these gaps? Just like that Georgia map I showed you a couple moments ago, where at the bottom it said some of the information was suppressed or incomplete. But what's great about prams is that they already have a bunch of reports that you can just find and pull things from. I don't think I have it on the screen, but so that you don't have to like get raw data and like analyze it yourself. You can just find reports that are already made and find your state. And if you're on a computer or a digital device, you can just Control F, find your state, find your community, and get that information. And a lot of it, because it's about risk assessment, it's about the experience of the mom, what was happening during her pregnancy, not her clinical outcomes. And so when you think of doulas and birth workers, scope of work really focusing on physical and emotional support, finding out more about the experience of a mom during her pregnancy could be helpful. Once again, none of these are perfect tools, but they are what we have. Another thing that's imperfect about prams, like anything else national, is the data comes out slowly. I think we just got 2018 data available, maybe 2019, but I remember a few years ago when we were like, when is the data coming? All that was available was I think during the last presidency, 2016 data was the only thing available the whole time. Like for the past 4 years, I don't think we had any new data. And then 2018 or 2019 just came out recently. So shout out to the folks at CDC for doing their thing. Something that was mentioned that Jessica said, and I guess Chanel also alluded to it in our conversation, was about, Chanel said it for sure, is this idea of like scaring people. When we talk about Black maternal death and we talk about Black infant death, and we talk about the experience of undocumented people, and we talk about kids in cages, and we talk about the fact that Breonna Taylor wanted to be a mother, and we talk about Serena Williams. These are very traumatizing and retriggering and very uncomfortable topics. It is not fun to talk about these things and re-experiencing them all the time. I tell people, when in my dissertation like experience, I wake up every morning and go to bed every day reading about dead moms. That's not fun, right? Like it's not. And so one tool that I find very awesome is this idea of asset framing. And it's the idea that when you're talking about your experience or you're talking about someone else's experience, this is particularly important for white folks, is when you're talking about somebody else's experience that is not yours, why are we always talking about the grim and the doom and the negative up front? We love to do that when we're talking about Black people. We talk about what she did wrong, what's wrong about her, what's wrong about her baby. No, there's something called asset framing. And I'm not going to go too much into this because I know I want to wrap up on time. But if you look up these links on YouTube or online, there is a fantastic gentleman who has a couple videos where he talks about what does it mean to reframe the conversation about something that is negative and turning it into something hopeful, just like Chanel and Jessica talked about earlier. We may not be able to solve white supremacy and racism in our lifetime, but we can probably talk about solutions and approaches in a hopeful manner that is both insightful and eye-opening for white folks and not spiritually exhausting for people of color that are working in that space. And so it's super important. Since I only have about 5 more minutes, I'm trying to determine whether or not I want to show you this last. So I'll just show it to you for awareness. I'm not going to workshop through it, but what I'll probably do is maybe make a video and then post it and you guys can see. CDC Wonder, as a data nerd, as an epidulalogist, as I call myself, and yes, I am epidulalogist.com. My CDC Wonder is so much fun. It's not complete, it's not everything, but it is a great tool. In CDC Wonder, you're able to see data that the federal government has collected one way or another, but you can see it all in one place. And so, for instance, if you do research around what's going on at the US-Mexico border and trying to advocate for families, if you're researching the past 7 years that Flint has not had clean water and the exponential increase in miscarriages and fetal deaths in the women there, you can click the fetal deaths page. I'm going to show you a couple of pages that might be of use and then go from there. Something that I find particularly useful is the infant deaths page. So this is for those of you who need to collect data about infant mortality that's not found somewhere else, or that you want to narrow it down to your community. The records link the baby's birth certificate and death certificate in the same page. So you're able to get information about the association between those two things, which I find particularly helpful. And what a birth certificate looks like if you're looking at birth data, which is always fun to look at, is I'm going to show you where it says expanded. Now, just only in 2016 were some upgrades made to the system. As you can tell, this page looks like it's fresh out of 1997. I really wish that they would make it a little bit more user-friendly. I understand that taxpayers' dollars need to go elsewhere, but I would really like this to be a lot more user-friendly. But let me show you something really cool that you can find on here. Birth certificates look different in every state, but some states collect a lot more information than others. And for the things that they all have in common, they're actually able to put here. For instance, obviously you can find your database on your state, or if you want to be more specific, you can open up where it says open, you can open up and find your county. If you want to compare Baltimore County to Montgomery County or something like that, or the different parishes in Louisiana. Unfortunately for DC, you cannot compare the different wards. I really wish you could for obvious reasons. It gives you the ability to filter by urbanization. So maybe you're doing like upstate New York versus the 5 boroughs. It's going to be very different information. But this is where I get excited, y'all. It extracts all kinds of demographic information from every time a baby is born and shows you the what do you call it, the anonymized results. You can find out a mother's where she was originally born, her education level, her obviously things like age. But then they also, in 2006, started putting information about the dad. And for me, that's particularly exciting because when you think about race and ethnicity, which, of course, are these man-made structures, but, a lot of times we kind of talk about white versus Black, but are we talking about a very specific experience of Black folks from the islands or Black folks from another place, or those that are Latinx or Hispanic but if they check a box, it's white. What does that mean when it comes to where the data is going, right? And so I just always find these things really, really interesting. And also, Black folks, we say it don't matter if one of the parents is Black, the baby's Black. Well, if it's a white mom and a Black dad, or a Black mom and a white dad, how does that change the outcome from a baby? Y'all know I'd be asking these questions in my sleep. There's information here about whether or not the mom already has other children or already had previous, the death of a previous child. Sometimes it is really important as a risk factor to find out if the mom has had other children. This is characteristics of the mom when it comes to, how much weight she's gained, or if she smoked during her pregnancy, and if she had other pregnancy risk factors that may have. And once again, this is on the baby's record. This is the baby's birth certificate record. For me, Section 7 is important because a lot of you all know I do a lot of work around hypertension. And since 4 out of the 5 leading causes of clinical leading causes of maternal death are associated with hypertension, I like to look at what's going on with moms in certain places when it comes to hypertension. This is interesting, but just so that you guys know, if you ever plan on playing with this, you can't do 2 categories at the same time. You can't do more than one variable at the same time. You have to do one and then go back, and one and then go back. So whatever. But I'm gonna workshop this for you guys in a different video. Here, whether or not the the mom had a past experience with sexually transmitted diseases. What happened during labor? As doulas and birth workers, we're always interested in like induction practices. This is, by the way, this always, number 10 always defaults to the most recent year. I like to click all years. Whether or not there is some difference happening at different times of the day or different months out of the year. There's some research coming out about, what happens if a mom goes to an emergency room on the weekend versus during the week. And this whole idea of, well, who's on call during the weekend? Is it a whole bunch of students? No shade to the students. Or is there actually somebody, that has more experience present on a Saturday at 2 a.m., or whatever. So this is really interesting. And then of course, you may be wanting to collect data regarding if it's a C-section or not, if it's a VBAC or not. And then I love this medical attendant category, which I'm hoping will be expanded because it's not well defined. But we are seeing, we can use this section to extract data about the increase of this other, who is other, right? Who are other birthing attendants? We do know that the data shows us that there's an increase of other, but who is that? It's not doulas per se, because it says the word medical, but how is the data being collected? Are they talking about us? Like, we don't know. So anyway, I'm not going to go through this ad nauseum, but that you can get information about if a baby came early or came small, APGAR scores. Shout out to one of our white foremothers, Miss APGAR, Nurse APGAR. There's information about gestational age based on both clinical measures and last menstrual period. So depending on if you do the clinical measurement or the more holistic measurement. Literally, you guys, like, this is all information that is available to the public for free. I didn't have to pay to log into this. I just went on here. The issue is it's hard to use. And so that's why, like I said, I do want to take time to like workshop through it, but I do want you guys to know that it's available. If you do research on Down syndrome, boom, you can get all the information that you need on CDC Wonder if you're trying to find it for your state or find it, for your community. And the how, like I said, I'll show you later. Let me do one more thing and then we're gonna close up for the day. A lot of times, okay, y'all, if any of you guys have had a conversation with me, you know that I'm very critical of this situation with the kind of insurance companies kind of directing physicians and telling doctors what they can and can't do based on whether or not they can or can't pay them. There's something I want to bring that into the conversation real quick. So the page that I use on a regular basis is the underlying cause of death page, because that's going to have all your codes when it comes to maternal death. I'm gonna actually I think I'm gonna do the middle one, 2019, I'm gonna do 1999 and forward. And by the way, this page that I'm clicking, I agree, is agreeing that I'm going to be ethical in my use of this data. I'm not going to show this to you today, and I kind of already talked about it when I talked about the baby's record. But I want to scroll down to something that you may be interested in playing with, and then you might have questions about, and that's disease codes. So ICD-10 is the International Classification of Disease, which is something created by the World Health Organization. And there's actually 11. ICD-11 is getting itself together. They're developing it, and I'm glad that they're developing it because they're adding social determinants of health in there in what they're called Z codes, Z as in zebra, Z as in zebra. And so they are adding characteristics of a person, whether they experience homelessness, whether they experience racism, whether they have a variety of different things about their social determinants that might have an association with their health outcomes, so that people aren't just like, oh, well, this is a clinical, this was a clinical thing. No, this might have been something else that systems and programs and structures and the government and partnerships and anti-racist efforts could actually address. So I'm excited when those Z codes are expanded in ICD-11, but I don't think we're going to see that for a while, y'all. So in ICD-10, we have all the different causes of the disease, which of course you can Google, and you can Google how they align with billable medical codes, because that's actually very important to take into account. I'm not going to go into depth, but I will tell you something. It's really interesting when you find out how people, how different doctors' offices decide to put some information on your bill and other information on your death certificate, but that's another conversation. So when you're looking at, as the last thing I say, and then we'll go, when you're looking at the ICD-10 codes for maternal death and infant death, there's a distinction that I want to make. And that's here. So it's P codes and O codes. So you see how O says pregnancy and childbirth, P says in your mind, you might intuitively be like, oh, okay, yeah, I'm gonna select both of those. Cool. Let me control, let me command, shift, and connect both of those. No, they're not the same. O is for the mom, P is for the baby. So O, there's an O in mom, or O, the shape of her belly. That's how I remember. O00 or O99 is specifically characteristics of the mom that are associated with her death record. And when you open it, in case you forgot me saying this, or you cannot find this video on YouTube, it'll be clear because you'll see the word maternal, and you'll see things about delivery on that code. P code is about the ped. It's about the baby. That's how I remember the P is ped. So, and you'll see that because it'll say newborn this and newborn that. And if you're trying to find out if in your community there is some increased rate of something happening, birth trauma is very interesting to look into. Obstetric violence against the mom, which is in the O95 and O99 sub chapter. It's really interesting to see that they actually write that down, that they're starting to do that. But I just really wanted to show you guys this tool because if ever you feel like there's no data for something, the answer is it's available, just is it accessible? It's on this website, but how do I use it? So I'll do a how do I use it later. Okay, I'm gonna stop my share because I know I'm a little bit over time. I really pray and hope that y'all can see my screen. Let me see in the chat if y'all, I often wonder about data and how much is real, especially when we talk about, yes, when we talk about Black and Indigenous people of color who have had reasons to not answer truthfully when folks are collecting data. That is something that we call in public health social acceptability bias. If you have a survey, if you have an interview, or if you have something where you're going to ask them, they're going to answer you something that's socially acceptable, especially based on the conversation we had. If we're talking about mothers who have formerly been incarcerated, or they don't want to get their kids taken away or something like that. Yeah, you're going to say one thing, but then it's like, okay, how accurate or how true it is. It's her truth. Her whole experience is her truth. But that goes back to what Jessica and Chanel were saying. It's not our responsibility to give you the truth if you're not trustworthy. It's their responsibility to be a little bit more trustworthy, right? One thing at a time, but you know what I'm saying. I just want to thank you all for, yes, girl, girl or guy. I'm sorry, y'all. I'm working on my gender pronouns. So please give me some grace. But I do want to thank everybody for tuning in. Like I said, I'll do subsequent videos where I can actually walk through, because I do want to show you all how it can make charts and it can make graphs, and it can really make some things that are tailored to the work that you do. And other websites, there's other websites that are free, but it's so easy to just tell people, oh, go find this online. It's another thing to like take the time and walk you through how to find meaningful, impactful data and information, especially if we expect our partners to do that. It would be good if maybe we knew how to do that, and then we could kind of lead them in that direction, kind of like I'm doing with you all today. Oh, thank you for the grace and thank you for the love. I want to thank you all so much for tuning in today. We have one more event this week for Black Maternal Health Week. I'm gonna drop it in the chat, where we are partnering with the Greater Washington Urban League to have a conversation about bias in health, bias in maternal health. And I'm going to be moderating that conversation as well. It's on Tuesday. So please register. I'm sorry, today it's Tuesday. It's on Thursday. So please register for that and tune in. And for that, I just want to say thanks again. Have a good day. Have a good evening. And happy Black Maternal Health Week. Bye, y'all.